Today, we're diving deep into the world of Step 1, exploring its significance and tackling some practice questions together. As you know, Step 1 is a crucial milestone in your medical journey. It's the first of a three-part exam series required for medical licensure in the United States. This exam assesses your understanding of the foundational sciences, particularly their application to clinical medicine. Your Step 1 score is a key factor in residency program applications, especially for competitive specialties. It's a standardized measure used by residency directors to gauge your knowledge and potential. A strong performance on Step 1 opens doors to a wider range of residency programs and can significantly impact your career trajectory. Remember, your Step 1 score isn't just a number. It represents your dedication, hard work, and mastery of essential medical concepts. It demonstrates your ability to apply your knowledge to real-life clinical scenarios, which is fundamental to becoming a competent and compassionate physician. Preparing for Step 1 can seem like a daunting task, but I assure you, it's an achievable goal with the right approach. In this video, we'll tackle some challenging practice questions and provide clear and concise explanations. Let's dive into our first example question, shall we? A 65-year-old male presents to the emergency department with sudden onset of crushing chest pain that radiates to his left arm. He describes the pain as a heavy weight on his chest. The pain began 30 minutes ago while he was mowing the lawn. He has a history of hypertension and hyperlipidemia, but is otherwise healthy. His blood pressure is 150 over 90 millimeters of mercury. His heart rate is 110 beats per minute, and his respiratory rate is 20 breaths per minute. His EKG shows ST segment elevation in leads 2, 3, and AVF. What is the most likely diagnosis? Is it A. Stable angina, B. Unstable angina, C. Acute pericarditis, D. Aortic dissection, E. Inferior wall myocardial infarction? Take a moment to consider your answer before moving on to the next section. Now, let's break down the clinical scenario we just reviewed. The key to solving clinical vignettes is to identify the critical clues provided. Our 65-year-old male patient presents with sudden onset of crushing chest pain radiating to his left arm, a classic presentation of myocardial infarction. His history of hypertension and hyperlipidemia further supports this diagnosis. The EKG showing ST segment elevation in leads 2, 3, and AVF points towards an inferior wall myocardial infarction, making option E, inferior wall myocardial infarction, the correct answer. When approaching clinical questions, always start by identifying the patient's key symptoms and any significant medical history. Then, correlate these findings with the diagnostic tools, like the EKG in this case. This methodical approach will help you narrow down your options and arrive at the correct diagnosis. Clinical reasoning is a critical skill to have for Step 1, and practicing with questions like these will enhance your ability to think through complex cases efficiently. Remember, understanding the rationale behind each answer choice is just as important as getting the right answer. This will not only prepare you for the exam, but also for real-life clinical scenarios. Let's move on to the next segment, where we'll discuss the vastness of information you need to master Step 1. Consider a 42-year-old female patient who presents with progressive shortness of breath and a non-productive cough over the past few months. She has no significant past medical history, but she mentions that she recently started a new job at a factory where she is exposed to various chemicals. On physical examination, you note bilateral inspiratory crackles. Her chest X-ray reveals diffuse interstitial infiltrates. Given these clinical findings, what is the most likely diagnosis? The key here is to focus on the patient's occupational exposure and the specific patterns seen on the chest X-ray. The combination of progressive dyspnea, non-productive cough, and diffuse interstitial infiltrates is highly suggestive of a diagnosis of interstitial lung disease, likely due to occupational exposure. Therefore, the correct answer is occupational interstitial lung disease. When tackling clinical vignettes, always pay close attention to the patient's history, especially any recent changes in their environment or lifestyle that could contribute to their symptoms. Correlate these findings with the physical examination and diagnostic imaging results to arrive at the most plausible diagnosis. This systematic approach will greatly enhance your ability to answer these types of questions accurately and efficiently. Remember, practice makes perfect. The more you engage with these clinical scenarios, the sharper your diagnostic skills will become. Let's continue to refine our clinical reasoning skills with another example question. A 55-year-old male presents with a sudden onset of severe chest pain that radiates to his back. He describes the pain as tearing and excruciating. He has a history of hypertension and is a longtime smoker. On physical examination, you notice that his blood pressure is significantly higher in his right arm compared to his left. Additionally, there is a new diastolic murmur heard on auscultation. Given these clinical findings, what is the most likely diagnosis? The key points to focus on here are the sudden, severe chest pain radiating to the back, the patient's history of hypertension and smoking, and the blood pressure discrepancy between the arms. These findings are highly suggestive of an aortic dissection. The presence of a new diastolic murmur further supports this diagnosis as it may indicate aortic regurgitation secondary to the dissection. Therefore, the correct answer is aortic dissection. In clinical vignettes, always pay close attention to the quality and characteristics of the pain, the patient's risk factors, and any physical examination findings that could point towards a specific diagnosis. Correlating these elements will enhance your diagnostic accuracy and efficiency. As you practice more of these clinical scenarios, your ability to synthesize complex information and arrive at the correct diagnosis will improve. Let's dive into another clinical vignette that you might face on step 1. A 42-year-old female presents with a 2-week history of increasing weakness and fatigue. She reports experiencing shortness of breath on exertion and occasional palpitations. Her medical history includes a recent upper respiratory infection. On physical examination, you observe pale conjunctiva and a systolic murmur best heard at the apex. Laboratory tests show a hemoglobin level of 7.5 gdl, a mean corpuscular volume, MCV, of 70 FL, and a reticulocyte count of 1%. Based on these clinical findings, what is the most likely diagnosis? Focus on the progressive weakness and fatigue, shortness of breath, recent upper respiratory infection, pale conjunctiva, and the laboratory findings. The low hemoglobin level and low MCV suggest microcytic anemia. The recent upper respiratory infection and subsequent symptoms point to iron deficiency anemia, supported by the low reticulocyte count indicating poor bone marrow response. Therefore, the correct diagnosis is iron deficiency anemia. In clinical vignettes, it's essential to correlate the patient's history, physical examination findings, and laboratory results to make the most accurate diagnosis. This method will greatly enhance your diagnostic skills and prepare you for real-world clinical scenarios. As you continue practicing these questions, your ability to integrate clinical knowledge and apply it to patient cases will become second nature. Now, let's dive into another example question that you might encounter on step 1. Imagine a 25-year-old male who presents with a 3-day history of fever, headache, and a skin rash. He reports that the rash started on his wrists and ankles and has now spread to his trunk. He also mentions recent camping trips in wooded areas. On physical examination, you observe a maculopapular rash with involvement of the palms and soles. Laboratory tests reveal a normal white blood cell count and mildly elevated liver enzymes. Given these clinical findings, what is the most likely diagnosis? The key points to focus on here are the fever, headache, skin rash starting at the wrists and ankles, and recent history of camping. The involvement of the palms and soles is particularly significant. These features suggest a diagnosis of Rocky Mountain Spotted Fever, RMSF, which is caused by the bacterium Rickettsia rickettsii and transmitted by tick bites. The patient's recent camping trips and the characteristic rash pattern are strong clues pointing towards RMSF. Therefore, the correct answer is Rocky Mountain Spotted Fever. When approaching clinical vignettes, it's essential to piece together the patient's history, physical examination findings, and any relevant laboratory results to make an accurate diagnosis. This methodical approach will serve you well in both the exam and real-life clinical practice. Keep practicing these clinical scenarios to sharpen your diagnostic skills and boost your confidence for step 1. Now let's go into another example question that you might encounter on step 1. Imagine a 30-year-old female who presents with a 2-week history of abdominal pain, diarrhea, and weight loss. She reports that the pain is crampy and worsens after eating. She has no significant past medical history but mentions that her father has Crohn's disease. On physical examination, you note tenderness in the lower right quadrant of the abdomen. Laboratory tests show elevated inflammatory markers and a mild anemia. Given these clinical findings, what is the most likely diagnosis? Pause 2S. The key points to focus on here are the chronic abdominal pain, diarrhea, weight loss, and family history of Crohn's disease. The crampy nature of the pain and the exacerbation after meals are also significant clues. These features suggest a diagnosis of Crohn's disease, an inflammatory bowel disease that can affect any part of the gastrointestinal tract but commonly involves the terminal ileum. The patient's family history and the clinical presentation are strong indicators pointing towards Crohn's disease. Therefore, the correct answer is Crohn's disease. When approaching clinical vignettes, it's essential to integrate the patient's history, physical examination findings, and any relevant laboratory results to make an accurate diagnosis. This methodical approach will serve you well in both the exam and real-life clinical practice. Keep practicing these clinical scenarios to sharpen your diagnostic skills and boost your confidence. Before we dive into the vastness of information required for Step 1, let's take a moment to talk about the importance of integrated learning. Imagine you're faced with a clinical vignette about a 25-year-old male who presents with a persistent cough, night sweats, and weight loss. His history reveals that he recently traveled to a region with high tuberculosis prevalence. On examination, you note swollen lymph nodes and a positive PPD test. Given these clues, the most likely diagnosis is tuberculosis. Now, you might wonder why integrating different subjects is crucial here. Understanding the pathology of tuberculosis isn't enough. You need to know the microbiology behind Mycobacterium tuberculosis, the pharmacology of anti-tubercular drugs, and even the public health implications of a TB diagnosis. This integrated approach helps you see the bigger picture, making it easier to recall information and apply it in a clinical setting. Integrated learning isn't just about memorizing facts, it's about connecting the dots. When you study physiology, think about how it relates to pathology. When you review pharmacology, consider its impact on clinical practice. This method not only aids retention, but also enhances your problem-solving skills, which are crucial for both Step 1 and your future medical career. Remember that the key to mastering Step 1 lies in integrating your knowledge across various subjects. This holistic approach will not only help you ace the exam, but also make you a better clinician in the long run. Now that we've discussed the importance of integrated learning, let's explore a practical example to see how this approach can be applied. Imagine you're presented with a question about a 30-year-old female who comes to the clinic complaining of severe fatigue, palpitations, and shortness of breath on exertion. She has no significant past medical history. On physical examination, you note pallor and a systolic murmur. Laboratory tests reveal a hemoglobin level of 8 gdl and an elevated reticulocyte count. Based on these findings, the most likely diagnosis is anemia. But to answer the question correctly, you need to integrate various aspects of your medical knowledge. First, consider the physiology behind anemia and how it affects oxygen delivery to tissues. Next, delve into the pathology to understand the different types of anemia and their etiologies. Then, review the pharmacology of treatments available for anemia and how they work. Finally, think about the clinical implications and how this condition impacts the patient's overall health and daily life. This integrated approach not only helps you identify the correct diagnosis, but also allows you to understand the underlying mechanisms and the best course of treatment. By connecting the dots across different subjects, you can navigate complex clinical scenarios with confidence and precision. Pause 2S. As you prepare for Step 1, remember that each question is an opportunity to apply your integrated knowledge. This method will not only help you succeed on the exam, but also equip you with the skills needed for your future medical practice. Let's explore another example to see how integrated learning can be effectively applied in a clinical scenario. Consider a question about a 45-year-old male presenting to the emergency department with acute chest pain radiating to his left arm, accompanied by diaphoresis and nausea. He has a history of hypertension and smoking. On examination, his blood pressure is elevated, and an electrocardiogram shows ST segment elevation in the anterior leads. Here are the possible answers. A. Stable angina, pos-0.3s. B. Unstable angina, pos-0.3s. C. Acute myocardial infarction, pos-0.3s. D. Pericarditis, pos-0.3s. E. Pulmonary embolism. The correct answer is acute myocardial infarction. To answer this question correctly, you need to integrate multiple aspects of your medical education. First, consider the physiology of coronary circulation and how ischemia affects the myocardium. Then, examine the pathology of atherosclerosis and its role in the development of myocardial infarction. Next, review the pharmacology of medications used in the acute management of myocardial infarction, such as antiplatelets, anticoagulants, and thrombolytics. Finally, think about the clinical implications, including the immediate management of the patient and long-term strategies to prevent recurrence. This integrated approach not only helps you identify the correct diagnosis, but also deepens your understanding of the underlying mechanisms and the best therapeutic strategies. As you continue preparing for Step 1, remember that each question is an opportunity to apply your integrated knowledge, enhancing your ability to tackle real-world medical challenges. Now that we've dissected the example question, let's see how this integrated approach plays out in a real-world scenario. Imagine you're on your clinical rotation, and a patient comes in with similar symptoms: acute chest pain, radiating to the left arm, sweating, and nausea. With your integrated knowledge, you immediately think of an acute myocardial infarction. You know that time is muscle, so you quickly obtain an ECG and confirm the ST segment elevation in the anterior leads. You recall the physiology behind coronary circulation and understand the severity of the blockage. You remember the pathology of atherosclerosis and how it can lead to such critical events. You promptly administer medications like aspirin and nitroglycerin, knowing their pharmacological effects and benefits. Your integrated learning doesn't stop there. You consider the patient's long-term management, including lifestyle modifications and secondary prevention strategies such as statins and beta blockers. This real-life application of your integrated knowledge underscores the importance of a holistic approach to learning. Each piece of information is not just an isolated fact, but part of a larger, interconnected web that enables you to provide the best care for your patients. As you continue your journey toward Step 1, remember that this integrated learning will not only help you ace the exam, but also prepare you for the complexities of clinical practice. Consider a scenario where a 62-year-old male patient presents with sudden onset of severe chest pain. The pain is described as crushing and radiates to his left shoulder and jaw. He is diaphoretic and appears anxious. You obtain an ECG which shows ST segment elevation in leads 2, 3, and AVF. This pattern is indicative of an inferior wall myocardial infarction. To answer this question, you need to integrate multiple disciplines: anatomy, physiology, pathology, and pharmacology. Anatomically, you should recall that the inferior wall of the heart is primarily supplied by the right coronary artery. Physiologically, you need to understand the implications of reduced blood flow to this region and how it affects cardiac function. Pathologically, you should recognize that atherosclerotic plaque rupture and subsequent thrombus formation are likely causes of the occlusion. Pharmacologically, you must be aware of the immediate treatments required to manage this patient, which include administering aspirin to inhibit platelet aggregation, nitroglycerin to relieve chest pain, and possibly a thrombolytic agent to dissolve the clot if percutaneous coronary intervention is not immediately available. This process of integrating knowledge across various subjects is crucial for both Step 1 and your future clinical practice. It ensures that you can not only diagnose conditions accurately, but also manage them effectively with a deep understanding of the underlying mechanisms. Consider a scenario where a 62-year-old male patient presents with sudden onset of severe chest pain. The pain is described as crushing and radiates to his left shoulder and jaw. He is diaphoretic and appears anxious. You obtain an ECG which shows ST segment elevation in leads 2, 3, and AVF. This pattern is indicative of an inferior wall myocardial infarction. Here are your options. A. Anterior wall myocardial infarction. B. Inferior wall myocardial infarction. C. Lateral wall myocardial infarction. D. Posterior wall myocardial infarction. E. Septal wall myocardial infarction. The correct answer is inferior wall myocardial infarction. To answer this question, you need to integrate multiple disciplines: anatomy, physiology, pathology, and pharmacology. Anatomically, you should recall that the inferior wall of the heart is primarily supplied by the right coronary artery. Physiologically, you need to understand the implications of reduced blood flow to this region and how it affects cardiac function. Pathologically, you should recognize that atherosclerotic plaque rupture and subsequent thrombus formation are likely causes of the occlusion. Pharmacologically, you must be aware of the immediate treatments required to manage this patient, which include administering aspirin to inhibit platelet aggregation, nitroglycerin to relieve chest pain, and possibly a thrombolytic agent to dissolve the clot if percutaneous coronary intervention is not immediately available. This process of integrating knowledge across various subjects is crucial for both Step 1 and your future clinical practice. It ensures that you can not only diagnose conditions accurately, but also manage them effectively with a deep understanding of the underlying mechanisms. As we move forward, we'll continue to emphasize the importance of this integrated learning approach. Let's take a moment to appreciate the art of integration in medical learning. Picture yourself in a clinical environment, confronted with a complex case that demands knowledge from multiple disciplines. This is where the true power of integration becomes evident. Consider another clinical scenario. A 45-year-old female presents with fatigue, pallor, and shortness of breath. Her lab results reveal a hemoglobin level of 7 gdl and a mean corpuscular volume, MCV, of 70 FL, indicating microcytic anemia. To diagnose and treat her effectively, you must integrate your knowledge of hematology, biochemistry, and clinical medicine. Hematologically, you understand that microcytic anemia can result from iron deficiency, thalassemia, or chronic disease. Biochemically, you recall that iron is essential for hemoglobin synthesis, and its deficiency hampers erythropoiesis. Clinically, you should evaluate her dietary history, menstrual cycle, and potential gastrointestinal blood loss. This comprehensive approach not only helps in identifying the root cause, but also guides appropriate treatment. For example, if iron deficiency is confirmed, you might recommend iron supplementation and dietary changes, while also investigating any underlying sources of chronic blood loss. By mastering the art of integration, you enhance your diagnostic accuracy and therapeutic effectiveness, leading to better patient outcomes. Now, let's put our knowledge to the test with another example question, this time focusing on clinical application. Imagine you're presented with a 28-year-old male who comes to the clinic with complaints of persistent headaches, blurred vision, and a recent history of weight loss. His blood pressure is elevated at 160/100 mmHg, and physical examination reveals bilateral papilledema. Laboratory tests show elevated levels of metanephrines in the urine. Here are your options. A. Essential hypertension. B. Pheochromocytoma. C. Chronic kidney disease. D. Cushing's syndrome. E. Hyperthyroidism. This scenario requires you to integrate your understanding of multiple medical disciplines. First, recognize that the elevated blood pressure and papilledema suggest a secondary cause of hypertension. The elevated metanephrines point toward a pheochromocytoma, a rare tumor of the adrenal gland that secretes excess catecholamines. To confirm the diagnosis, you would consider ordering imaging studies such as a CT scan or MRI of the abdomen to visualize the adrenal glands. Additionally, you would need to manage the patient's blood pressure carefully, often using alpha blockers before considering surgical removal of the tumor. This question exemplifies the importance of integrating knowledge from endocrinology, neurology, and clinical medicine to arrive at a diagnosis and formulate a treatment plan. It also highlights the type of complex, multi-step thinking that is essential for success on Step 1 exam. By practicing these types of questions, you not only prepare yourself for the exam, but also develop critical thinking skills that will be invaluable in your medical career. As you prepare for Step 1, celebrate your accomplishments along the way, no matter how small they may seem. Every step forward, every concept mastered, every practice question conquered is a testament to your dedication and resilience. Step 1 is a significant hurdle, but it's important to keep it in perspective. It's just one step on your path to becoming a physician. Your journey is about more than just a score. It's about pursuing your passion for medicine, honing your skills, and ultimately making a difference in the lives of your patients.